Well, good morning, Dr. Pieter Kersemakers. Thank you so much for being with us. And wanted to see if you could introduce yourself and your clinic and talk a little bit about how you think about value-based care.
Yeah, so my name is Pieter Kersemakers indeed. I am a GP. I am the medical director of the clinic branch of Arts and Zorg, which is the, let's say, biggest first-line healthcare company in the Netherlands. So we have 21 clinics spread all over the country, well, mostly condensed in the Hague area, so that's where we are now, in the center of the Hague. This is where it all started. This is my clinic. I've been working here for 5 years now, and the company has started this 20 years ago, and it grew and grew. Meanwhile, we have the asylum seekers healthcare in the Netherlands. We have a whole IT branch, and the branch healthcare centers is what I'm responsible for. So I work here in this clinic as a GP 2 days a week, and the rest of the week, and also during these 2 days, as you can imagine, I am kind of in charge of the medical issues of the 21 healthcare centers. And before this, as we just talked about, I worked in China for 5 years for International SOS, and before that I worked nearby in a healthcare center. That's where the non-Western immigrants live, very nearby, so that's what I did for 10 years to provide them with Dutch basic healthcare, GP medicine.
We know in the health literature, whether it's in Europe, in the US, there's a lot of discussion about value-based healthcare.
Right, yes.
And a subcomponent of that is often the alternative payment model.
Yeah.
So how would you think about both of those terms? What do they mean to you?
As you know, we have a system like that within Arts and Zorg. So a bit of the history. So we decided a few years ago, after some talks, it was actually before I came into the company. So when I came in, it was already there. But of course I know some stuff about the history, and I was also the doctor, even before I was the medical director, I was in charge medically of the things, to put things in place that would make the system work. But anyway, so what it started with, we were thinking of indeed alternative payment methods just to try to provide our patients with better healthcare, well, very generally speaking. We were looking for things to make healthcare less, let's say, money-driven, less based upon perverse impulses. So in that sense, we were looking for things to make our healthcare professionals act more in line with evidence-based medicine, with what's good for people, what's good for our patients. So then we talked to our main health insurer. So in the Dutch system, we work with different insurance companies. They're all government controlled and stuff, so I don't know if we have to dig into that now, but anyway, our biggest one is Mensis, and we decided and we agreed with them that we would implement this new system where we would try to get rid of all these perverse things like doing extra consultations, or I've worked for an
give us some examples, because this is a big deal and it happens all over the world. One of the key barriers.
Yeah. First of all, I should say that within our company, the doctors work with a salary. So that makes it, in a way, a tiny bit complicated in terms of explaining it to them, because for the doctors in our company, things might not have changed tremendously. Although the push from the managers in our healthcare clinics became less, because the doctors could work like they were, to do the stuff that they're good at. Well, it's helping patients. But your question is, could you give an example? Well, for example, let's say you would do a small surgical procedure, like removing a mole, which is basically a simple procedure. You could do such a thing, or you could also say, well, I'm not really interested, I need to see more patients, so I'll refer to a dermatologist or to a surgeon who's going to do that for me, so I have more time to see other patients right now, because, well, there needs to be a turnover. Right now you could say, well, this is something I like, it's good if I do it myself, and it will reduce the costs of, well, the healthcare for our population, so I'll do this myself. And you can get trained, so I'll do this small surgical procedure myself, so and the patient will not be referred to the surgeon for a lot of money or to the dermatologist, and I can do the follow-up checkups myself. This is an example. Another example could be that you would have follow-ups of patients that are unnecessary, just because you need to write your bills for the consultations, which is something we don't need to do anymore. If it's not necessary, we don't ask patients to come back. If it is necessary, we can ask them to come back 20 times, and other patients not, because it doesn't matter in this case, because we have this system where we get paid by our health insurance companies as a whole, so we don't need to write these bills anymore. We can only think of what's good for that patient at that moment.
So You talk a little bit about the insurers and how you're not the old way of billing, the volume-based way of billing for every activity. You're paying your doctor's salary.
Right.
Great. How is Arts and Zorg, the clinic, the business, being paid by Menzies and or other insurers?
Yeah, so the general system normally is that the patients pay their subscription fees. They can decide which insurance company they want in the Netherlands. There's the competition aspect in that sense. It is it's a capitalist society, of course, so we need to have some kind of competition. In that sense, years ago, they decided to make that happen through competition within these insurance companies. So they can offer a better deal for different patients. So there's always a few euros difference, whatever. Anyway, patients have their subscription, and then the insurance companies pay the GP, in this case, because the Dutch system is based upon the GP. So they pay the GPs for every patient that has a subscription at that clinic, a subscription fee again to the clinic. So basically, even if the patient doesn't come in, the GPs will have their subscription fee from the insurance company.
So that's like a per member, per month, per patient, per month.
Indeed. So even if we don't do anything, we would have that money. But to keep your clinic up and running and to make a bit more money, you would have to do surgical procedures. You can if you do palliative care, for example, you make a lot of money for that. So all these things, or if you do a house call, you charge, and that gives you the extra money.
In addition to the
subscription, right? Indeed,
Okay.
That's how it works. Well, in this case, in our case, so our main health insurance company, Menzies, and we have been discussing how much a patient per year would cost. The mean of that, so the subscription fee and all the extra things we do, all the moles that we remove, all the IUDs that we put in, stuff like that. So we came to a general basic fee, and that's what they pay us for every patient. And no matter if we don't see that patient, or if we see the patient 100 times, that's what they pay us.
So it's roughly based on the historical spending.
And also the benchmark. So we also benchmark with a similar population, and every year it's adjusted, and we look at what would that population cost, and the insurance companies try to pay us that amount of money.
Yeah, is that benchmark drawn from the national database I've heard about that has all of this data on patients all over the country?
Yeah, but it's also tried to benchmark a similar population. So let's say they wouldn't benchmark a clinic like this with the non-immigrant clinic that we just talked about, because the costs are very different. Although we try to spread it all out because we have different clinics in different areas of the country. So, but that's what we try to benchmark with similar populations, and indeed it is drawn from that data bank.
That helps us really understand the starting point. What is the Arts and Zorg model? And you've done a great job, I think, talking about that. I know you have only been here 5 years. The company's been around for close to 20. Was this always the model, or was there a problem that your predecessors presumably built this model to solve a problem? What drove you to have this model, because it's so different than others around the country?
The system before that, so let's say it started a few years ago, and the system before that was, as I just explained, with kind of money-driven, sending bills, whatever. And I still think that our doctors are totally not money-driven because they have a salary right there. That's the advantage, I think, in working in a clinic like this. But the system before that was still, you had to write your bills, because every small procedure, every house call, everything had to be charged. So to change that, it was first of all, the reason to change that was first of all an experiment. So there was one of our clinics in the east of the country, and that's the clinic that Arthur Hyen did his PhD on, where we implemented that system. So one fee for every patient, nothing else will be charged anymore. We just created awareness in that clinic, and we had some small changes, and there was not really much happening in that sense, but still the cost of that population went down. So that's why we thought, well, the experiment seems to work, so let's spread it all out over the entire company. And that's when Menzies said, all right, let's do that. Let's give you that fee for your entire population. And after that, the other insurance companies thought, well, this actually might be a nice idea, so let's follow. So all our insurance companies, everybody gives us that specific subscription fee. So we don't need to charge anything anymore. It is a bit complicated because what we have the subscription fee, but we also have an investment part. So with which we are supposed to do interesting things that would triple aim, reduce cost, improve quality, improve the experience, as you know what triple aim is. So we have to think of programs, of experiments that will give us that result in the end. So it's all triple aim, we try to reduce cost, etc. And so sometimes we do have to pay, we have to write bills, or we do have to pay bills. Let me give you an example. There's these doctors from this nearby hospital that come into our clinic, to do ultrasounds. So other clinics that don't have this payment method will pay for every ultrasound. Let's say the insurance, it's very complicated, the insurance companies will pay for that ultrasound. In our case...
Because they're not your employees.
Right. Okay. So what we do, we pay for the ultrasounds. We pay the company because our insurance company has asked us to work triple aim to find all these solutions. Well, we thought doing ultrasounds within the clinic will keep them out of the hospital. It's a good idea. So we do these ultrasounds here. So our company pays that. So it won't cost the patient anything. So if I want to do an abdominal ultrasound, whatever with the patient, I'll tell the patient, it won't cost you anything. Come in next Monday. Patient comes in. I pay that bill.
And Mensis doesn't pay.
Well, Mensis
You're at risk.
Mensis pays us, and Mensis asks us to do these interesting experiments. So we think that, and we have to justify that, of course, we have to explain to Mensis what are we doing. So we pay this bill for this ultrasound, and out of our own pocket, but it's money that comes in from Mensis. And we can explain, because we think this is triple aim, we think this reduces costs. Well, we won't send the patient to it's cheaper to do it here. The patient won't get entangled in all these hospital things where they want to do extra scans or whatever. So it's just, and it's also improved quality or experience because it's in the GP clinic. There's no waiting list. It's all within 1 or 2 weeks. You have your ultrasound. So we think this is a perfect triple aim example of reducing costs. And it also explains the complicated system where we, as a company, pay the bill of the patient. So you understand? Yeah.
Yes, well, I want to dive a little more for clarity. So I understand the notion that we have this in spots in the US of a capitation. So Mensis paying you a per member per month or per patient per month capitated amount.
Right.
And it's inclusive of everything, or is anything excluded from that? Like, you said this ultrasound, you have to use that money for that.
So they don't ask us to do that. If we find it interesting, we can decide to do that. We have to justify. We have to, at the end of the year, we have to tell Mensis what are we doing. What are the projects that we're doing? There's many different projects that we're doing. I can give you more examples.
So in your example where the patient needed an ultrasound, you chose to do it in-house.
Yeah.
Does Mensis pay you extra for that?
No, no.
It's part of the per capita.
It's part of the per capita. There's an amount of which we think, all right, this is our general need that we have to pay our salaries and everything. Yeah. And there's a part we have to invest in interesting programs. We also do lean projects, for example, or I have this thing that I showed Arthur where we try to prescribe medication according to the specific scientific evidence, where you have a diagnosis. Imagine a patient comes to my office, I find that he has pneumonia, so I diagnose pneumonia, or 74, whatever, ICPC, and then I press another button, and the button comes up with a preferred prescription. So this is how you reduce costs, how you prescribe according to the scientific evidence. So this is also a thing that we can do within that specific amount of money, because that's what we're talking about, right? So we get this specific amount of money from the insurance companies that we pay our salaries with on our buildings, whatever, and we have this specific amount that we have to invest in special projects.
Yeah.
One of the special projects that I just explained was the ultrasound. This is another project. This was my first big project, to try to get my doctors to prescribe according to these protocols. Just by using a button. The money that we spend on that was, doing a roadshow, going to all these clinics and telling the doctors, hey, there's this button, because doctors don't know that. It's in their system, but they don't know it. So then we explain, and then we try to get them to use it. And then there's, of course, people think, oh, well, should I? Well, why should I do that? It's 2 extra clicks. Then they discover, hey, it's actually easier to do that because I don't need to write amoxicillin 500 milligrams, blah, blah, blah. It's just 1 click and the prescription pops up. It's another example. Yeah.
Now I saw in the clinic when I walked in that you've got a pharmacy, you've got physical therapy.
Yes.
So there's a lot of general kind of wellness maintenance going on. Is the cost of drugs included in your capitation, or is that a separate?
It's not included in the capitation. It is included in the general calculation. So what we do at the end of the year, we try to calculate how much does our population cost. And that includes prescriptions, referrals for appendicitis. All the things are included. And then we're trying to decide by the end of the year, how much did our whole population cost, and we're benchmarking that with similar populations. And if we manage to reduce those costs for the whole population, it could even be that we as clinics are more expensive. Because if in the end the whole population is cheaper,
Yes.
then, we manage to get a shared savings. And then what we've decided is that with Menzies, that if we manage to reduce those costs, then a bit of it will come back to us, a bit of it will go to Menzies, and we invest it again in new AAA projects.
Now, do you have arrangements? Your docs do a great job. They reduced the spending this year.
Yeah. Mm-hmm.
Does some of that money come down to them as bonuses? Because I know they're
Kind of.
salaried.
Yeah. Yeah.
They are the people on the front lines, the soldiers doing the hard work
Yeah.
to try to move things forward.
Yeah.
Do they benefit?
A tiny bit, yes, but not very much. But we do try to give them an incentive. So we have an agreement with Menzies that we have to, give them value-based healthcare. So all these benchmarks, we have that. These benchmarks, these indication figures, need to show Menzies. We take out a few of these and tell our doctors, listen, this is what we agreed upon with Menzies, with our insurance company, and we ask you guys to do the same thing. So if they manage to do that, and within specific percentages, whatever, they get a bonus.
So some of those specific metrics that are your benchmark, your goals, your objectives with Menzies, sounds like a lot of quality types.
It's all quality.
Related.
It's all quality outcome related. There's also things in this bonus system. It's not huge, to be clear, right? So if you really want to make money in the Dutch system, you don't want to become a GP. It's okay. Our salaries are totally all right. So it's not tremendous, but it's okay. And we give them a small bonus, and they're very happy with it. It works pretty well.
So as a point of comparison, roughly, if I'm a new primary care doc coming into the clinic, or maybe I've been around a couple of years, roughly how much does a person make per year?
So it's roughly, if you work full time, it's something like 100,000 euros gross. Right?
And bonus opportunities could add roughly how much?
A month salary or something. So
Okay.
something like that divided by 12.
So
Yeah.
maybe 8-ish,
It's-
8,000, something like that.
I think it's less now that you mention it, but yeah.
But a nice little bonus.
It's nice, and people are happy with it. It's nice, definitely, yeah.
I can imagine, I know this may have predated you, you're talking to docs about a big change in their model.
Yeah.
On salary, having these performance metrics, reporting, changing how you practice medicine. Your button pushing was one tiny example. I'm sure there were 100 more that were
Yeah.
even bigger.
Mm-hmm.
What were the docs' concerns, the physicians' concerns, and how did Arts and Zorg come about winning them over?
First of all, it is important that our doctors are just aware of the system. The biggest problem is, I think, that a lot of them are not even aware of it. We're not aware of it. So because they have their salaries and they just keep on acting as they've been doing. So the challenge for us was, and it still is, to explain to them that we have this system and this is what you're supposed to do. And if you do use that button, or if you do the ultrasounds in your clinic, it does make a change for us. And because there's a huge turnover of doctors, and we don't have enough GPs in the Netherlands, so they can just shop around. So we have clinics where there's actually no solid team of doctors. So that makes it very difficult to implement the system. I must be honest about that. So we try to explain it to them. There's also clinics with solid teams that have been working here for 10 years and they know exactly what they're doing. They come up with new projects. So it also works like that. So the biggest challenge is to make it clear to doctors that we have that system, and it does make a difference. If they don't refer, if it's not necessary, it does make a difference in the end. The model didn't change from day 1 to 2. They're not driven by huge amounts of money. That's not the way they work.
More intrinsic motivation.
I think so, yeah. So the challenges that we had with that is, it's simple to motivate them to use that little button, to explain the system to them, to come up with new ideas. I could give you another example what makes it difficult. In my clinic, we have that system. Then there's other clinics that think, all right, we want to have the same thing. Let's also get these ultrasounds into our clinic. But if we will do this everywhere, a huge amount of that money would go to the ultrasound because, as you know, we pay these ultrasounds ourselves. Yeah. So if we would implement that system in all of our clinics, a huge amount of that investment money that we have would go into these ultrasounds. Whereas we're also trying to find ways and to implement different systems, to experiment with it, to try to get doctors to use that prescription button, or we've had other projects where anyway, I can also dig into that, but this is also a challenge that we have.
A lot of what you've described sounds like amassing a lot of the need for analysis.
Yeah.
So in your team, do you have some data analysts, biostatisticians, people that dig into this data to do reporting, or to inform the team about how these measures are working?
Yes, we have. We have a huge business intelligence department, and we can give people feedback at any time. It's improving, of course. Some things are difficult. Let me give you an example. What we're trying to do is to give people feedback on their prescriptions, but also on their referral percentages. So, and we can give them this feedback at any time, a month, a day, whatever. So we can always see how much did I refer to a dermatologist. So we're trying to reduce that amount, and we can give the feedback to doctors. But then the thing is, a challenge with that is, how do you compare these things? Because a lot of our GPs work part-time, so they work 3 days, the other guy works 5 days. So, and if you start to compare these percentages, it's quite difficult. So those are the challenges we have in that. Or people will say, well, my population, I work in this area with non-Western immigrants, and demand is so high, so of course I refer more. So this makes it also difficult to compare. But we're doing our best, and we can give people feedback real time on their prescriptions, on their referrals, all these things. And if we come up with new ideas, we ask our guys from business intelligence to come up with new stats, and we discuss it, and we think what would be a good way of presenting it. And then the next challenge is, of course, how do we present it to the doctors? So we have these clinical meetings where we show them the stats and where we show them their referrals. It can be quite confronting, right? So you can discuss with each other, why, so how come? Okay, maybe you can teach me some stuff, right? And this is also the goal of the whole system. We'll question yourself about your referrals. And we'll write some notes on that, and we spread them within our clinic, which will hopefully, in the end, reduce the amount of referrals again. It's another example of a project. It's all very different projects that you see, ultrasounds, pressing a button, talking to each other, all these models we use, all these experiments. Yeah.
On that note about the physicians having that conference together, talking about patient care and comparing their statistics with each other, I could see in some environments, maybe some company cultures, that might not go well because people have our pride, we can be embarrassed. So talk a little bit about what the culture at Arts and Zorg is like to make that happen in a way that's building up, that's edifying of people and positive rather than a negative force.
Well, I must say I was surprised in a positive way, because I've been doing a lot of these conferences, and I was very positively surprised about how open people were and how much they were willing to learn from each other. So I don't know if this is very specifically Arts and Zorg, and because they're Cellulite GPs and they don't have this incentive of, I don't know, they're value driven, I think, but this is, as I noticed, the company culture. And I came from this organization. It was a very different approach. If we're talking about that company culture, yeah, it's there. And I do think that the company attracts specific types of doctors. I do think that the Dutch healthcare system in that sense we do a good job on training our GPs. It's not money driven, it's all quality that we talk about, and it's all about implementing the right protocols, etc. We as a company take care of all the admin stuff for our doctors. So the only thing they need to think about is, how do I provide my patients with the right healthcare? And on top of that, come up with all these quality projects that we do. I think people truly realize that this is what it's about, and that we provide them with that. So, yeah.
Nice.
Yeah.
So thinking about, it's a little about now thinking about giving advice to others, you have this really unique model, this really healthy company culture. Mm-hmm. You're pursuing quality and achieving it, it sounds like. You're bringing down costs in most respects. If I'm at a different organization, whether it's here, the US, elsewhere, and I want to build a model like this, who needs to be at the table to design it and implement it successfully?
Of course, I don't know exactly how different models in different countries work, how the model of the US is, but our advantage is, of course, that we have a specific amount of clinics and doctors. We have something like 200,000 patients in the Netherlands. So with that, we have a certain leverage and we can do stuff. So I think you would need a specific bulk of clinics, of patients. And what we needed was the people that were in charge of those 200,000 patients and the insurance company. And we started to talk to each other, and we decided to come up with that model. So this is basically how it went. And so how that would go in other countries, it depends on the system, I guess. I don't know how the insurance things in the United States, for example, exactly work.
Well, I wanted to just drill into that a little more. So you had in the beginning Menzies, then other insurers, you doctors. What about from Arts and Zorg? Did you also have some business people, maybe like a finance officer or a quality control officer or somebody like this who also was involved? Who else was around that table?
Indeed, it was our medical director, it was somebody from finance, it was somebody who studied health policy, so to look at it from different angles. So those were people from our company, and from Menzies it was also their medical advisor, their account manager, general practitioners, people like that. And then of course there was this guy, Arthur Hyen, who of course was trying to give it a specific scientific layer, who was willing to do some research with that experiment. And this is also very important, I think, because you can just come up with ideas, but it's also important to get feedback on it and to see if it really works. And that's what we're still trying to do, of course.
Well, let's go there. I like that. So how does it work? Evaluation. How do you evaluate the model on a regular basis, and how is it working?
What we try to do every year is to have specific figures, indicators, and that's what we discussed with Menzies. And it's always difficult because what do you measure, right? So, and we try to come up with specific things, but it's actually, to be honest, it's never enough. I would like to give them with more stuff, but it's not limitless. We can't provide them with everything. So we try to decide upon a few things that we measure. We provide them with information on those doctors' meetings, for example, right? This is also something we measure. How many of our doctors have these meetings where they discuss their referrals? And they write notes on that, so they have to hand them in, and we don't give that to the insurance companies, but I check that. So we check those things. We also, one of the things that we also do is we're very high on digital things. So for example, we implement video consultations, stuff like that. So we also have specific indicators where we tell our insurance company, we promise you that we will implement the system on video consultation, and in the end we give them feedback on that. Did we do it? So it's not only, let's say, the plain basic figures of your cholesterol level, it's also, did we talk about referrals? Did we actually reduce our referrals? Things like that. So
I'm just thinking about some of the theories or the structures and models in quality improvement. I'm thinking of the Donabedian model with structures, process, outcomes. And I know a lot of the systems focus more in the area of process. Are you checking cholesterol? Are you checking blood pressure, HbA1c for diabetics? How much do you measure the processes of checking these things, these preventive measures that are appropriate, versus holding yourselves, your docs, accountable or reporting to Menzies on the outcomes of them?
Yeah, we do. So we do both.
Okay.
We do both. Yeah. The interesting thing is that Menzies is also interested in these process things. So it's not only interested in the outcomes. It wouldn't be fair towards our doctors. And it doesn't tell you enough. Your cholesterol levels might be okay, but if you have a specific population where it's just impossible to reach those levels, you have to come up with other ways of measuring your outcomes. Yeah.
And so you work on those proposals as a team and then propose it to the insurer?
Indeed. And they also sometimes come up with new ideas. So they ask us, could you maybe next year do something like that? This year they want us to provide them with information on our quality improvement system in general. So we have this system in place where we report complaints or small possible errors. With that, we try to come up with new quality improvement measures, and the insurance company wants us to give them information on that. Did you actually do that? Did you actually report your near mistakes? And what types of quality improvement projects did you develop from there on? And I thought it was a good idea, actually, because it's all quality driven. It tells us much more about the quality of care, I think, if we provide them with that info.
And they have financial incentives for you around the processes or the outcomes, or both?
Yes, so if we manage to reduce the costs of our population as a whole, it doesn't go into the pockets of the doctors or the company. We invest it again into new projects. So in that sense, we continuously improve, hopefully, the quality of care.
Yes. So think about the different populations And I like you gave the good example. You've got an immigrant population, they have their own social determinants and challenges versus a more traditional population, or maybe a wealthy neighborhood versus a poor neighborhood.
Yeah.
You aim to compare your performance against the right groups,
Yes,
the right
yes.
populations. So that means either you have to find a population that's just like it somewhere else,
Yeah.
or you make some statistical adjustments.
Yes, right. Yes.
How do you go about doing that? Can you give some examples how you do that?
To be honest, I don't know exactly how that works. And it's mainly something that Menzies does if they compare the costs. And I know that it's very difficult for them as well. So that's why it's also very difficult to know if we really managed in reaching those shared savings, because we only have information on our own company. They have all the information on all the, at least they have access to, because they have this population of, well, not even 200,000, that's our population, but it's only 1/5 of that, of course, who has insurance with Menzies, or maybe a bit more because they're our biggest insurance company.
Because like you, in the US, a lot of clinicians, especially if they're in maybe an inner city or some other area where those social determinants of health are extra challenging for them, say, our patients are sicker. We hear that all the time. Our patients are sicker.
Everybody thinks that their patient is sicker.
Well, and that can be true.
It can be true.
And so we have some
Yeah.
mechanisms now for testing the ways in which that's true and maybe trying to adjust the metrics, the money
Yeah.
to adjust for that.
We do have indications of, let's say, social layers. So we know what areas are more difficult, where they have lower income. So we do know these things in general, but if you want to dig into very specific things, ask Menzies indeed about that, yeah.
Great. Is there any more detail you can share about the performance on the quality, or the evaluation on the quality measures? Are there any of those that you have a number committed to memory that you think, oh, we did such a great job, we dropped A1C this amount, or blood pressures or something?
Yeah, well, for example, it's a project that we also do in our clinic where we collect patients with heart problems, so palpitations. It's a good example of things that we encounter every day. People come to our clinic and say, I have palpitations. Well, you just know that in 99% of the cases it's nothing. We all have palpitations, right, every day. So what do we do with it? Well, I can refer you to a cardiologist, or I can also just wait and ask. We do an ECG, we collect these ECGs, and we collect the patients, and every 2 weeks the cardiologist calls in and we discuss these patients with the cardiologist. So we show them the ECG, we discuss the medication, everything, the whole case history, and then the cardiologist gives an advice. So the patient doesn't even see the cardiologist. So then we give the feedback to the patient. It reduces the amount of referrals with 70% or something. So only 30% of those patients will eventually end up, and if they're referred, the cardiologist tells us to do a 24-hour ECG, for example. So we do that, and then with the feedback of that, 99%, it's just the extra heartbeats that people have. In most of the cases, the patient in the end is not referred. So a reduce of 70%. Just by collecting some patients, doing ECGs, calling in the cardiologist once in 2 weeks for half an hour. I know the cardiologist now, so if I have a question, I just text him a message like, I have this thing, within 5 minutes often I have this. So there's also some very positive side effects, because you know your colleague there, and you can also ask him things. So this is an example. We can also I can give you more examples, like the taking photographs of skin lesions, of skin of eczemas, and then you send it to the dermatologist. And again, I don't know the exact figures there, but I know that it reduces the amount of referrals. Also with something like 60-70%, I don't know, but it's a lot of things, and you also learn from it. Can I give you one more example? The orthopedist. We have an orthopedist that comes into our clinic every few weeks, and he actually comes into the clinic. So he sees patients with one of my colleagues. I've also been there, and I've also seen my own patients together with that orthopedist. I learned that these orthopedists, they, let's say before that, I thought that I had to refer a patient with knee problems and that the orthopedist would do an MRI. I've discovered now that nowadays, these orthopedists, if you have a certain age, they just do an X-ray. They tell the patient to do physiotherapy, and if in the end, if you're 70 years old and you really can't walk anymore, all right, we'll give you a new knee. Well, this is something I can do myself, right? I've learned this. I can tell my patient who is 50, 55, and has some knee problems, I'll do an X-ray. Well, I see you have some arthrosis, physiotherapy. I can bypass the whole orthopedic thing now. So by doing that, you learn from that those consultations. And I think if he would come in, let's say 1 more half year or something, we all know how he works. And we think, well, we can do this myself. He can go to another clinic and teach the doctors there that it's not necessary to do MRIs to send people to orthopedists unless you're young or you have, your knees locked, right? And there are specific things for which you do need to refer. But to do an X-ray and to send a patient to a physiotherapist, it's pretty easy. I can do that myself. So it reduces the referrals tremendously, these things.
From a population perspective, I love it. You're reducing the population cost.
Yeah.
And potentially, I don't know if it's a problem, reducing the workload or burden that would be referred to. And you talked about orthopedic, dermatology, as well as cardiology. Yeah. Now, how do those people feel though? You're not sending them the business you used to.
True.
Are they going hungry now?
Yeah, no, that's a good question.
And they're giving you some of their time. Is that out of the goodness of their hearts, or do you pay them a small fee for their...
I've also wondered about this. How does it work? And it's a good question. We have a limited amount of money in the Dutch healthcare system, and also the hospitals have their budget, so they have to do with a specific amount of money. So they have to reduce their patient flow, otherwise they have to see patients for free. So that's one of the reasons why they decided to cut down on their inflow, because they're only allowed to see a specific amount of patients, because that's what the insurance companies tell them. That's just the way it works. If they keep on seeing patients, well, in the end, the government or the insurance companies will say, right, that's enough for now.
And those specialists you're talking about are salaried by the hospital?
Well, some of them are, but most of them do write their bills. But still, if you've reached your budget, it kind of stops. And you would have to ask a hospital how the exact system is. This is one of the things that I was also wondering about. Why do these people do this? Why do they, help us in reducing the influx of patients in the hospital? Well, that's why. Because if they see too many patients, they don't get paid for it.
So they have some maximum, some cap they are bumping up against.
Yes. And that's why they're trying to reduce the cost, because in the end, you have to see patients. If the patient will come in, you're still a doctor, so you do want to see the patient, but it doesn't, because you don't get paid for it anymore.
So if you're in a system where that doesn't exist, you may need some other mechanism, maybe a retainer, a smaller fee. Okay, something else. I got it.
Yeah.
But I love the explanation of how you've done that model. Again, I can see another type of design of a healthcare model. Maybe a little different mechanism would be required, but you could make the same impact.
Mm-hmm. The dermatologists, for example, if you send them a picture of a skin thing, of course they charge for that, right? So it's a little bit, but they still charge for it.
Less than an office visit, probably?
Much less, of course. And we pay for it ourselves. So that's the strange thing about our model. We pay the dermatologist. It won't cost the patient anything. We have this part of our fee that we get from the insurance companies that we have to use to work AAA to reduce costs. So we pay the dermatologist to look pictures that we took and we sent with our phones. Yeah.
I mean, the terminology we might use in my classes with my students is you, Arts and Zorg, the primary care, you're at risk for that type of care.
Indeed.
So if you choose to use it, you pay for it.
Right.
But also, if it escalates to a higher level, it can come out of your money as well. So this is the most efficient way to handle that patient's need.
That's true, yes.
Very exciting. Okay, so we have colleagues from another country or within the Netherlands, and they're not doing this. What's your parting advice for what do they need to do to build a value-based model that has different payment and do it well? They want to be successful. They want to avoid the pitfalls, the risks of failure. What are the things they have to do and the things they need to avoid?
Well, it's an interesting question. It is difficult to answer because we have this very specific Dutch system where, as I explained, we get all the help we need from the insurance companies, from the specialists. And I've also worked, as mentioned, in a different system, worked abroad, where the specialists were mainly trying to get as many patients as they wanted. But I also noticed they want to be your friends, because in the end, they will get referrals. Try to be friends with the specialists. They can teach you a lot, and they can learn from us, right? From the GPs. What I would also advise is try to make it as easy as possible. So like pressing the button when you have a specific diagnosis, nothing easier than doing that. But you got to make sure that your systems are up to date. So one of the questions that I get from my GPs is, how do I know if I click the button that I really get the right protocol? It is indeed amoxicillin for pneumonia and only 5 days, 3 times 500 milligrams. So we have to make sure that all these protocols are in that system. So if you click the button, pneumonia, click the button, amoxicillin, that's the right thing to do. So make it easy and make sure that your protocols are up to date. Be friends with your colleagues and try to figure out where you can get the best healthcare for that patient at that specific point in time.
So communication, relationships between the specialists, the GPs, that's key. I hear that. I also hear about educating the physicians about how the system works.
Right, yes.
And some of that's technical. Can any group of physicians do this, or do you need a certain electronic medical record for this to even be viable?
Well, I think that's also one of the key things. We have to make sure that it's there, that it's in place. So this button, I'm sorry to come up with the same example over and over again, but we make sure that this button is there. And it is there. So if we implement a system, we make sure that it's got to be easy, it's got to be accessible.
And anything about the personnel or infrastructure for tracking all the quality metrics and the spending metrics, anything really necessary there that other clinics would have to ensure that they have this?
As I explained about the business intelligence graphs that we can present our doctors with, it is there, but I noticed that it's difficult. And if I try to explain to the business intelligence guys, the IT guys, how to come up with these graphs, they're not doctors, so they don't entirely understand. So it takes a while. It takes often a lot of meetings to explain to them, the IT people, how to present those graphs and how to compare. You know, they don't understand that some doctors also do some managerial stuff, so they don't see that many patients. So that might be the reason that their amount of referrals is low. They have no clue about that. So it takes a while before the IT guys understand what doctors are doing. So the communication between IT and the working floor and the doctors is essential in that. And take your time for that. You know, try to explain. It takes me often lots of meetings to explain to them how we work and how a referral works. Or if you talk about the feedback I get from well-prescribed medication, if I look at myself, for example, I think that I work according to the protocols. Well, then I go through my own graphs and I notice suddenly, oh, I've only been right 60% of the cases. Oh my God, 60%, how's that possible? Then you go through your own records, and I go with these IT guys through things. And then you also notice, for example, that it's very much examples, right? So a patient comes to you with a gastric pain or something, you prescribe omeprazole. Then the patient in the same consultation tells you, well, you know, I also have this headache. I'm sorry, but could you also prescribe some paracetamol or acetaminophen, in American, I think, right? So, all right, I do that. So then you have a code with gastric pain, omeprazole. That's right, but then you have gastric pain, paracetamol, which doesn't go with that code. So the IT guys, they don't understand. They say, well, you prescribe paracetamol with, you know, gastric pain. How does that? But it's also, you know, the heat of the moment. You have 10 minutes per patient. The patient says, walking out, you know, touching the doorknob. Could you also prescribe that? Or my heart medication? Right, you do it. So then it all mixes up your stats. It all mixes up all the feedback that you give, that you get. So that makes it pretty difficult to give feedback in terms of value-based healthcare. This is a difficult thing. I've seen my own stats, and I've seen that I only prescribe, let's say, something like 60% right. I think it should be much higher. It forces me also to open up a new consultation, headache, paracetamol, acetaminophen, which costs me a bit more time. If you're loaded with patients, you do physical examination, you have to write it down, you don't have time to do all of that. That makes it difficult.
So as an educator, my colleagues and I, we're training the healthcare managers of tomorrow who are coming to work at clinics like yours, in administrative, non-clinical roles, the hospital, insurers like Menzies, again, Netherlands or more broadly around the world. What do we need to know as educators and our students, as the people who are on the business side of this, your advice for us, so how we can be more effective in value-based care?
Well, I think I just gave a good example, and I don't have the solution for that, but be aware that there's a discrepancy between the actual workflow and all the stats that we have. So you can't always tell doctors that they have not been doing the right thing because it's just a matter of logistics. Be aware of that, but I still think we can find solutions for that. I think it is very important to try to give doctors enough time, which is easily said, I know, but the amount of referrals, the quality of care would go up, at least if there's no incentive to do MRIs and blood counts and all of that stuff. If it's just value driven, then this won't happen.
Well, we'll make sure also that our administration management students are getting a lot more time with the clinical colleagues to understand them better, because that's what I hear you going at is if we on the non-clinical side can better understand you, the way your work goes, that you are actual human beings with
Yeah.
the same challenges, getting tired on Friday as everybody else, we can probably do a better job of being your partners.
Yeah, right. But there's also from the other way around. We doctors should also understand the things that our managers are doing and that our, for example, our IT guys are doing. Within Arts and Zorg, we have this whole IT branch, and we're trying to make work for the doctors easier. But the doctors don't often believe that. So this is also one of my jobs, because I talk to both sides. So, for example, we have the system now where patients can just log in, they can put in their own appointments, they can ask for their repeat prescriptions, whatever. It's very easy, and the doctor doesn't even need to look at that. Sometimes, well, you have to check things, but it would make it very easy. Well, we have a lot of doctors that don't trust it. They just want them to call and they want to talk to them. So there's also a challenge for the doctors to trust those new systems that will make their lives easier, and also to trust the system. Yeah.
Dr. Pieter Kersemakers, thank you so much for your time. We really appreciate it. I think there's so much that we all can learn from what you're doing at Arts and Zorg. And so we'll make sure to refer our viewers to the website as well. So thank you so much for your time.
Yeah, thank you.